Morning. Good morning, everyone. Good morning, everyone who is with us. We have, just so you know, we have several hundred participants today in this very, very important webinar to discuss COVID-19 in our own community. I'm Denny Saunier, President and CEO of the Canton Regional Chamber of Commerce. And we're very honored to be able to bring you up-to-date information from our local healthcare providers in our community and experts at what they do. I want to thank both Ed Roth and Tom Strauss, Aultman Health Foundation and Mercy Medical, the CEOs of both. If you remember, several months ago, they were with us as we were going into this COVID situation, and nobody really knew at that time what might lie ahead. And we've come quite a distance, and I think it's fair to say that everybody would realize we are at a critical stage of this pandemic in our community. And I want to thank them very much, and everyone who's associated with both facilities, Aultman and Mercy, for what they're doing. They are critical to the health care of our community, and we are so fortunate to have top-line health care as we do. The chamber, the chamber is a business advocacy organization, and we represent a little bit over 1,800 members throughout Stark County and our immediate region. And obviously, the economy is extremely important to us. It's important to our members, many of them being small business members. And as we hear, when we hear from officials in Columbus or in Washington, whether it's the governor or the president-elect, or Dr. Fauci or other experts, they're a fair distance away. And many times I think we believe that, well, that's happening somewhere else. It's not happening maybe in our backyard. Well, the truth of the matter is to have a strong economy, you have to have a healthy community. And as important to us at the Chamber with a healthy economy is also the healthcare of our community, our members, employees, our families, all the citizenry of our community. So today, at least from my standpoint, I think what's important to realize is if we're going to continue through this at this most critical stage and keep our economy, our local economy moving forward and hopefully soon begin to really come out of this, we have to stay healthy. And I know that from speaking to many people in our community that our two health care facilities, once again, both Aultman and Mercy, are basically fighting a battle that needs our help. And so today, we wanted to bring you people that aren't in Washington or in Columbus or some other part of the country. We wanted to bring you people that are really our neighbors. And these are our local health experts. These are the people that we may see, again, in our neighborhood or in the community at some function that we can rely upon and depend upon and understand coming from them where we are exactly. So today, it gives me a great deal of pleasure to say thank you and welcome our panelists. We have with us today Dr. Nahad Boutros, who is an intensivist at Aultman Critical Care, and Gunther, Chief Nursing Executive with Aultman Healthcare Delivery System, Dr. Frank Kaeberlein, who is the Emergency Medicine Mercy Medical Center, and Barb Yingling, Chief Nursing Officer of Mercy Medical Center. Also, just a footnote, because of today's time that we want to spend with this, and because of the critical time they're spending at what they do to keep us safe and as healthy as possible, we will not have time for Q&A at the end of the event. So I want to welcome our panelists. Thank you so much for what you're doing. Thank you for the time that you're spending with us today. And I'm going to ask Dr. Kaeberlein to kick off the conversation.
Hear me?
Yes.
Thank you, Dennis. Yeah, so first of all, I want to start by saying most things I'm talking about here, you can find online on the CDC website. So if you kind of forget something I said, just go online, look this stuff up, and you can find it very, very readily. So I'm going to start by talking about kind of COVID-19 symptoms. So, COVID-19 is a virus, it's a coronavirus. And so the symptoms are kind of similar to what you expect with a lot of viral infections. You're going to see sometimes very mild symptoms like runny nose and congestion, fatigue, fevers, chills, and other things like cough, shortness of breath, muscle aches, headache, and then even some GI symptoms like nausea, vomiting, and diarrhea. And then one thing we see a lot of with this virus is loss of taste and smell. And that's, for some reason, it's a very kind of a specific symptom that when you do have that loss of taste and smell, that's probably going to be coronavirus, given the large community spread. And if you listen to all those symptoms, of course, there's a large number of them. And so it's very hard to distinguish, a simple cold versus a COVID-19 infection, because the symptoms are so similar to other typical viral infections. So you have to be very wary when you have these symptoms that you actually might have coronavirus. So the next question is then, okay, if you have coronavirus and you've been diagnosed with that, when do you want to come to the emergency department? So most people actually will get better by themselves at home. They'll have to isolate themselves. We'll talk about that in a little bit. But again, most people will not need to come to the hospital, especially if you're a younger person, you're healthier. You'll generally do quite well at home with very mild symptoms. You might just have some congestion, almost just like a cold, basically. The problem is that people who are older, who have other medical problems like diabetes, obesity, hypertension, lung disease, things like that, they can get into trouble and develop more serious complications. And so the biggest thing I tell people is that if you have coronavirus, you've been diagnosed with that, if you start getting more short of breath to the point where you have a hard time, walking and functioning, that'd be probably a key reason to come to the emergency department, because that's the one thing we really look for is patients who are very short of breath and have very low oxygen levels. And then kind of related to that, obviously, if you develop things like confusion, significant chest pain, extreme weakness or lethargy, all these kind of symptoms of just really severe low oxygen levels. That's kind of a trigger to come to the emergency department. Otherwise, again, for most folks, you can do well at home, isolating yourself. At the same time, of course, we don't want people to not come to the emergency department if they have other medical problems. We'll talk about that also in a little bit here. But again, the key is, if you get more short breath, certainly come to the ER at that time. So that kind of leads into the next kind of issue, which is, quarantine versus isolation. And we kind of use these terms a lot interchangeably, but they're actually kind of two separate things. If you actually have the infection, and you've been diagnosed with coronavirus, you do have to isolate yourself. And you have to isolate yourself for at least 10 days. And you have to make sure you've had no fever for at least 24 hours, and you have to have improving symptoms. So all three things, 10 days and no fever for 24 hours without using Tylenol or ibuprofen, and improving symptoms. That's if you actually have, a positive test result and have coronavirus. Some people ask, what would I do if I have a positive test if I didn't have any symptoms? So the CDC recommends in that case that you isolate for 10 days after the date of your positive test. And to isolate means isolate. You have to really stay apart from any other contacts. You have to not share utensils. You have to not share common rooms. Try to use a separate bathroom. You really have to isolate yourself from other family members to avoid spreading this disease. Because the issue with coronavirus is that it is very infectious, much more so than influenza, for example. So it can spread very rapidly with very limited contact. And so kind of related to that, then people hear about the word quarantine. And so quarantine is what you do is when you have close contact with an infected person. You yourself don't have the symptoms yet, but you had close contact. And so how's that defined? So the CDC says, well, close contact occurs if you've been within 6 feet of somebody who has the illness for more than 15 minutes total. Not at one time, but 15 minutes total, less than 6 feet. Or you provide home care to somebody who has COVID-19, or you've had direct contact, kissing, hugging, that kind of thing, or you've shared, eating or drinking utensils. So if those kind of things occur, you do have to quarantine yourself to avoid spreading it to other people because you're at high risk for having been infected. And when you quarantine, the CDC currently recommends 14 days is the ideal number of days. That's based on the incubation period of the virus. They recently have kind of modified that a little bit, and they said that if you've had no symptoms for 10 days, that you might be able to stop it at 10 days, but you have to continue to monitor yourself and wear a mask and distance. And then if you have a negative test result, you might be okay at 7 days. Again, with a negative test result, as long as that test is done at least 5 days after you had the exposure. And again, you still have to monitor and mask. And across all these things, I want to emphasize the importance again of wearing masking and distancing, which is really important to avoid spreading this amongst our community members. And so people then often ask, well, what happens if I come to the emergency department? What's going to happen when I get there? Because obviously they're concerned because they're afraid that of what they might encounter there. So all the hospitals are kind of doing the same thing. They are putting pretty much every patient in a mask, whether you have possible corona symptoms or something else. Pretty much all patients get placed in masks, and that's because there's so many patients who are asymptomatic and they actually have the disease. They don't know they have it. So we put masks at Mercy. I'm sure Aultman does the same thing, pretty much on every patient. If you have the disease, the illness, or we strongly suspect you do, we actually will place patients in our emergency department into negative pressure rooms, which kind of circulates the air away from the rest of the department and out into the environment where it dissipates. So we do that as another safeguard to kind of separate those patients who are at higher risk from COVID-19 or actually have COVID-19. And in addition to that, obviously, all the caregivers you're going to see in any hospital are all going to be wearing masks right now. Everybody from the doctors to the nurses to the techs to the housekeepers, everybody's wearing a mask in the hospitals for all the reasons that we talked about. And of course, the patients that actually have the illness, who we think strongly have the illness, we actually will put on additional protection as caregivers, gowns and additional personal protection equipment to kind of keep ourselves safe also. So again, if I want to kind of summarize this, I encourage people to stay up to date with the CDC recommendations. They'll cover the symptoms, they'll cover quarantine, they'll cover isolation. All those things are on the CDC website. And I would just encourage people as much as possible, keep wearing your masks, make sure you distance, and try to avoid these situations where you have close contact with people in very close enclosed environments, which is typically indoor settings for long periods of time. That's kind of where we get these kind of big super spreader events. And that's where we're seeing a lot of community spread right now. So with that, I'm going to pass it off to Barb Yingling, who is a CNO here at Mercy. She can talk about hospital forecasting and capacity. Barb?
Thank you, Dr. Kaeberlein, and good morning, everyone, and thank you for joining. I am going to talk about the hospital capacity, and as we enter into the different phases of COVID patients presenting to our hospitals, none of us were really surprised that Stark County turned purple level 4 last Thursday. The total number of COVID patients arriving to our emergency departments and at our hospitals has changed significantly over the past 2 to 3 weeks. To give you an idea with those numbers, on October 9th, Mercy Medical Center alone had 32 COVID patients. On November 9th, we had 50. And on December 9th today, we have 94 COVID patients. And last week we did have a high of 108 COVID patients. So with these volume changes, both at Mercy and at Aultman, we've had to adapt in multiple ways. Our internal capacity management at Mercy, we've had to make multiple changes to our nursing units. We've actually had to flip 5 of our nursing units into all COVID inpatient units in order to accommodate the capacity and the patients. So that has been a real issue and a trying time for everyone, our staff included. And in order to accommodate that volume of COVID and non-COVID patients at both hospitals, unfortunately, we needed to stop and prioritize surgeries that required an overnight stay. And both organizations started that process on December 1st in order to gain capacity for our patients who are presenting to the emergency department, and also to help us with additional staff members. You might remember back in the spring when we did this, it was a mandated government order, basically was done to help us conserve on PPE. Thankfully, right now, our PPE supply is very stable at Mercy, and I believe at Aultman as well. But what we've ran into this time with this surge of patients is the reality of having enough space for our patients in the hospitals and having enough staff to care for them. Both hospitals have been working through our well-organized emergency planning process. Each hospital has a functioning incident command center. Both Ann Gunther and I serve as the incident commanders for our hospitals. With that process, it involves the Stark County emergency management teams, our health departments. We also have the Stark County COVID advisory team. We serve as members and participate in multiple weekly calls to remain informed at the state, regional, and county levels. And this is very important for us so that we understand the status, and it can also help us with forecasting that Ann will talk about. The state of Ohio is broken down into 8 regions. Aultman and Mercy we're in Region 5, which is led by Dr. John Crow and also Sarah Metzger. They serve as great resources for us for our Stark County hospitals. Then Ohio is broken into 3 major zones. Region 5, which we belong to, is in Zone 1, which is then led by Dr. Bob Wiley from the Cleveland Clinic. The frequent calls that we participate in, we involve a report out from our surrounding hospitals in our regions and in our zones, and it helps us with prioritization. It also helps us with important equipment needs such as PPE and ventilators. So everyone on these calls are willing to and ready to assist us in all the various hospitals whenever we have needs, and we all help each other out. Stark County has a transfer communication hub line, and this line is rotated between our 2 hospitals, Mercy and Aultman. For example, Mercy has the line this week, Aultman will have it next week. We're responsible for Stark County and also the southern counties below us, Holmes, Tusk, Carroll counties. These hospitals, what we do then, we help the hospitals that have COVID or even non-COVID patients. If their facility is full, we help them find a bed either at our facility, or if all of the facilities are full in our surrounding areas, then we have a process that we start calling the hospitals north of us, such as in Akron and Cleveland. So we are always helping to accommodate each other. Mercy and Aultman are working very closely together and helping each other with bed capacity if we need to. But if everything's at 100% capacity in Stark County and surrounding, like I said, we call north. And 2 weeks ago, both of our hospitals, Mercy and Aultman, had to transfer patients to northern hospitals. So that is the reality of our situation. So I'm going to hand it off to Ann Gunther now, the Chief Executive Officer for the Healthcare Delivery System at Aultman, to talk about load balancing and forecasting. Ann?
Thanks, Barb, and good morning to all, and thank you so much for joining us this morning for this webinar. To just expand on what Barb had talked about with this load balancing, that's sort of the term that we've adopted across the state, is when we have patients in our facilities and we're unable to accommodate them within our facilities, then what we try to transfer for them to our local hospitals. So for example, here at Aultman, if we have a patient that comes in through our Canton emergency department and our inpatient areas is unable to accommodate at that point in time, then we will transfer the patient either to Aultman Oroville, Aultman Alliance, or at times even over to Mercy. Again, and this is just to avoid overwhelming our hospitals with the volume that's coming through our doors. Another item that we are very focused in on is forecasting. So obviously, living in the moment is one thing, but what we're trying to do is stay ahead of this, we call it the third wave. And so we have teams that are together looking at forecasting ahead of what kind of volume can we anticipate. And just like Barb said, then we can look at our current capacity and whether we need to convert existing units into COVID beds or we need to open up additional capacity, then we have that ability to do so. So just to kind of take you back into the spring, when this first came around back in March and April, we did some forecasting and we actually were in consultation with experts across the state, and that was with the Cleveland Clinic, Ohio State University, the Ohio Department of Health, as well as the Ohio Hospital Association. And that point in time, they were estimating around 2,000 patients coming through our doors. And that was in more of a 5-county region, as Barb talked about, our county plus some southern counties. Well, as you know, that they really overestimated that volume. It really didn't come to fruition. So with this now, this third wave that we've come to, we've actually learned a lot from that initial forecasting. So right now, our methodology for forecasting is based on historical data. So again, we can track from now into the beginning of this back in February. We look at the number of new cases that are coming through each day. We're looking at our positivity rate, and that is a 7-day positivity rate that we're calculating, as well as looking at the number of patients that are currently in our facilities. And again, we look at length of stay for that, both at a critical care level and a non-critical care level. So we have been tracking this now over a month, and I will say it's been very accurate with that data that we're using to calculate. And so we actually know our growth rate every day. And here at Aultman, across all our facilities, we're around a 3 to 4% growth rate every day. So with that, if we have zero mitigation efforts across our region and our county, we are predicting between Aultman and Mercy to be 300 to 400, possibly 500 patients sitting in our hospitals by the end of the year. And so that is why our message to wash up, mask up, back up, and even boost up with the flu vaccine right now is so critical for us to move forward and to really make an impact on decreasing the number of cases. So with that, I'm going to turn it back over to Barb, because we also want to speak to you about healthcare worker capacity as well as our workforce shortages. So Barb?
All right. Another challenge that we're facing is employee exposures. So that obviously, and I know that's probably no surprise, as many of you as business leaders are challenged with that as well. But employee exposures are hitting both organizations, especially with this last wave. And many of our employees are being impacted and becoming positive with COVID-19 as well. So Ohio's 7-day positivity rate as of yesterday was 16%. And at Mercy, as patients are presenting to us, our 7-day positivity rate is running between 25 and 30%. So what that's telling us is the community spread is real, and we need to pay attention because these numbers just continue to increase day after day. So we're finding that the majority of our employees, the exposures are due to community spread now versus the hospital environment. And this is a constant, again, as we participate in calls, these are the same things that we're hearing from our Northeast Ohio hospitals as well, and in our region, is that it's more due to community spread versus hospital environment. As Dr. Kaeberlein mentioned earlier, all of our staff that are taking direct care of all patients are in their PPE, they're in a surgical mask and eye protection as well. Obviously, those patients caring for the COVID patients, they're protected with N95s, eye protection, gown and gloves, everything. Our number one journey through this entire process has been protecting our staff, because obviously we need our staff or we can't take care of our patients. So they're our number one priority as our PPE supply does remain stable. So even with the protections and the increased community spread, we continue to deal with staff exposures and COVID staff members. On an average, Mercy, we're having 35 to 40 employees across the hospital out for COVID, and then add on top of that the call-offs, because obviously our staff has been directed, do not report to work if you're sick, or you have any symptoms whatsoever. We don't need to take the chance of, spreading that. So on top of that average of 35 to 40, then we have call-offs on top of it. So it's very challenging. So the community spread is one of the main reasons we stopped patient visitation almost a month ago, is to protect our staff from community members that would be coming in and potentially spreading it to our staff. So another reason you're going to hear us say, mask up, back up, and wash up, and don't gather, please don't gather. And Ann's going to discuss some of the staffing strategies that we've dealt with.
Sure, thanks, Barb. So, we talk about just our staff and the exposures. And here at Aultman, we're averaging about 60 to 70 staff members off a day as well. And so that really has really challenged us on how to staff our units. And it's not just here, Stark County, but it is a national, it is a state, and it's a regional concern. And in fact, I am finishing my term as president of the Ohio Organization for Nursing Leadership here in the state. And I've actually had the opportunity to participate in statewide forums with the Ohio Department of Health and their preparedness team, and to talk about what we can do to mitigate some of these staffing shortages. And so things such as, reaching out to our medical and nursing deans and have them connect up with us, and how we can maybe utilize students in order to help supplement staffing. In fact, the National Guard has been deployed out to the nursing homes to help staffing. And again, it's not only in the hospitals, but it's also in our congregate care and our nursing home environments that they're having the same issues. Obviously, we've been reaching out to some retirees. So, some of our former employees that maybe have retired, that maybe we can bring back in a capacity that, is adaptable to them, but they can also contribute to the care. Of course, we've already incentivized our staff through a monetary means, but as you all know, that's a short-term solution. Barb talked about this, that our staff is under tremendous pressure to be able to care for a COVID patient, and it is a lot of resources that is needed to take care of it. And so we are dealing with staff burnout, and we're also dealing with mentally tired and physically tired staff as well. We also have an option to turn to staffing agencies for help, but that actually has turned into a bidding war now. We have registered nurses from staffing agencies that are asking between $150 and $200 an hour to come staff our units. So, at this point, that may not be an option. It may be, but if they're not even available because everybody is needing the staffing agencies, that's another item we just move away from. Another strategy is telemedicine services. So a lot of our employed physician offices, as well as some independent physicians, have moved to a telemedicine platform that they're using to really connect with their patients and try to avoid the demand of coming into the emergency department. The state is actually looking at expanded scope of practice standards, so maybe waiving a few of those for athletic trainers, paramedics, and as well as college students in health-related programs. We've also deployed some alternative staffing models, such as team nursing. We've also instituted resident and medical students who are now assisting in areas of our critical care units, as well as our hospitalist services. We've also reached out to the local high schools. Many here in Stark County have medical technician programs at the high school level, senior level students. And so we've outreached to Joe Chaddock and his team on, is there a possibility we could utilize them for some help in our staffing? So you can see there's a lot of innovation that's going on for staffing, and it's something that we every day we are evaluating. In fact, we staff every 4 hours across all of our areas. So again, it's an area of focus, and it's even more important why we really need to mask up, back up, and wash up. So with that, I'm now going to turn it over to Dr. Nihad Boutros, who is our Medical Director of Critical Care Medicine here at Aultman. And we're going to turn a little bit of the conversation now to the treatment of COVID. Dr. Boutros?
Yes, good morning. Thank you, Anne, and thank you everybody for the opportunity. As Anne mentioned, I'm one of the intensive care doctors here at Aultman. So I would like to share with you just what we learned about that virus briefly and what we have used in terms of medications and equipment to battle. So looking at this one, it sounds like first 1 week we're dealing with the acute viral illness that my colleague from Mercy nicely explained, the usual symptoms, and most patients will do very well. The second week of the illness and beyond, it seems probably it's no longer a real acute viral illness or acute infectious disease that what we're dealing with, as most of the all the manifestation and complication probably related to how the body reacted to that virus. With that intense response of inflammation that's quite dysregulated, where the body produces different chemicals. And that's what is hurting the patient, and that was leading to those organ system failure that we are seeing, whether that the lungs or the kidneys or the heart or elsewhere. And of course, this doesn't happen to everybody. Most patients do well, but the one who have at least one risk factor are at risk for that. So in terms of therapeutic and intervention that we've done, whether that's in the intensive care unit or the floors, I would like to summarize that as follows. Now, first of all, everybody who's in the hospital has at least severe disease, meaning they do have hypoxemia and they need to be on oxygen. Since I divided that disease into 2 stages, theoretically, the acute viral illness, and later on how this somewhat crazy dysregulated immune response, I would like also to divide our therapeutics accordingly. So early on, our effort should be focused to contain the virus, stop the replication of the virus, prevent the virus from entering the cells and causing the damage. And what we have for that, we have remdesivir, which is FDA approved, and it is an antiviral medicine that is given intravenously during the hospitalizations. So the literature has taught us that this medicine probably does not reduce mortality. However, it enhances recoveries. Patient gets better faster. So based on the data and based on the experience and we have seen, who should get that virus? I think the best candidate, who should get this medicine? The best candidate would be somebody who admitted to the floor early in the course of the illness, and they are on oxygen therapy, or what we call low flow nasal cannula, 1, 2, 3, 4 liters of oxygen. It seems that those are the patients who probably draw the most benefits. We have used it, of course, for people who have more severe disease, more advanced disease. They're requiring a machine, we call it non-invasive positive pressure ventilation, even patient on mechanical ventilation. Quite frankly, the benefit among these population is a big question. So our best candidate when you just admit to the hospital and you are still doing okay on a low dose of oxygen. Who should not get it? It seems that patients who do not have hypoxemia, meaning that they can maintain oxygen saturation of 94 or greater, once again, they're not benefiting from this medicine in terms of altering the course of the illness. So once again, you just admitted your level of oxygen. Seems like this is really the opportunity when you can give this medicine. Once again, that's remdesivir, and it is given intravenously. Another effort to contain the virus and preventing it from doing its things on the body is convalescent plasma, which got a lot of publicity. So that is a plasma that we retrieve from the sera of patients who get infected and survive COVID-19. And they have a acceptable concentration of the neutralizing antibodies. So those are the antibodies that they can attack the spikes that exist on the surface of the virus and prevent the virus from entering the cells and causes the damage. It has been used widely throughout the country at large part of clinical trial, as of recently outside the clinical trials. And what we have learned about this, once again, probably the best time to give convalescent plasma early on during the course of the illness, when somebody just got admitted, low flow oxygen. That where the data are suggestive, not really conclusive, that it might reduce the progression to severe illness and has its impact. It seems that when we use it for more advanced and severe disease, probably it's not having as much of an impact. So at Aultman, we are trying to give it early on. For the last couple of months, we are not doing it for people who are on ventilators or BiPAP, or they have much more advanced disease. So that's what we try to do when patients just get into to the floors. What about the second week? And actually, that most patients are hospitalized during that second week of illness. Most hospitalization occurs around day 8. Most ICU admission occurs around day 10 to 14. And it is amazing. A lot of patients actually read the book and do that. So what we have used steroid, the old cheap medicine, in an effort to modulate that immune response that the body exhibits. So meaning just try to calm it down and preventing from doing more damage. And that is dexamethasone. Actually, another form of steroid will work just as well. So who should get steroid? Any hospitalized patients who is on oxygen. Any hospitalized patient who's on oxygen, low flow, high flow, non-invasive positive pressure ventilation, mechanical ventilation, and ECMO. And the sicker the patient, the most reduction in death rate that we see. So this is so far the only medicine that we do know that it reduces mortality for patients who have severe COVID illness or COVID with critical illness. It is cheap, it is available, and this is also supported by the literature as more than one studies, the most important one, the recovery trial, that it did show that there is significant reduction in mortality when we use steroid. Who should not get steroid? So we should not give steroid to any patient who does not require oxygen therapy, as it seems like there's no survival benefits. We should not give steroid during the first week of the illness, meaning somebody have those manifestation of acute viral illness. And of course, their oxygen saturation 94% or greater. I think that is the time to allow the body to clear that virus, and probably the use of steroid may impair that abilities. So anybody who's admitted to the hospital who requires oxygen therapy and higher must be treated with steroid because it reduces mortality. We should not use a steroid for patients who have mild disease or even moderate disease without hypoxemia. And for us and for a lot of hospitals, I suspect that has been a game changer because we noticed since we started using back in March that less and less of these patients are decompensating on the floor and coming to the intensive care unit. We started with a ratio, floor to ICU ratio, almost 1-to-1. Now we are 1-to-4 or 1-to-5, meaning for every 4 or 5 patients on the floor, we have one in the intensive care unit. And my personal opinion, it's all probably due to steroid. What are we excited about now, and what do we see the future? Of course, in addition to the vaccines, we have the monoclonal antibodies. The one that we have here at Aultman is called bamlanivimab. So this is monoclonal antibodies. Those are manufactured, produced by human cells, antibodies. So what they do, they bind to the virus spike and they prevent further damage. So who should get this medicine? Any person who has mild to moderate disease. As a reminder, mild to moderate disease that you have symptoms and no hypoxemia, meaning your oxygen saturation greater than 94%. And have at least one risk factors. Those risk factors includes obesity, diabetes mellitus, hypertension, significant cardiovascular disease, chronic obstructive pulmonary disease, advanced age, one of the top actually risk factor along with obesity, and others such as chronic kidney disease, liver disease, immunosuppression, and things like that. And the purpose of this therapy is to reduce the progression to severe disease, and then you're requiring ER visit, hospitalization. And this drug now is EUA, meaning has the FDA emergency use authorization, and that based on one published trial. During that trial, if we focus on the higher risk patients, the use of this medicine has reduced hospitalization. So for the intervention groups, hospitalization rate was 4%. For the placebo group, hospitalization was 14.5%. Here in Ohio right now, 6 to 7% of all positive are being hospitalized, and death rate for hospitalized patients around 20%. So we just started using it at Aultman, and of course the data are limited. There's a lot of challenges with this logistic challenge with this medicine. How do you identify the patient? Where do you give it? Our ER colleagues have been just amazing, and we're so grateful to them to identify those patients, do the rapid test, and they are positive, try to infuse it. And my colleague from Mercy is an ER doctor, and I'm sure he can appreciate how difficult that things, because you need the bed, you need so many other things. So to keep the patient, we wait for the test, 1 hour infusion, 1 hour monitoring. But this is something that we are very excited about. I think those are the main things that we are doing right now. Just to mention one thing, we know steroid has helped us. It's very difficult to have a firm conclusion about the contribution of other medications, but we do know one thing, that our death rate has decreased, and at large because we have learned about that disease and we have used new medications. So that's where we are. I think I'll stop here.
Okay. Thank you, Dr. Boutros. And I'm gonna kind of continue on the theme of the treatments, because certainly what's capturing the news media and what's capturing all of our attention is the vaccine, the COVID-19 vaccine. And I'm sure many of you have been reading or listening or talking about the vaccine. And in fact, yesterday it was announced that the FDA found that the Pfizer COVID-19 vaccine is to be safe and effective. And also tomorrow, the FDA's Vaccine Review Committee will then vote on whether the vaccine will be the first authorized in the US and start shipping. And actually here at Aultman, we were just notified by Pfizer that they are ready to start shipping as soon as we get that vote from the FDA. Many of you may know or don't know that Aultman has been named a pre-positioned hospital for the Pfizer vaccine. And that's really because we have the ultra cold storage unit that it's required for that vaccine. And that freezer is located here at the Canton location. And we have been working collaboratively with the Ohio Department of Health and finalizing our vaccine distribution plan. So as soon as the FDA approves, the EUA is issued, and Pfizer starts the shipment, we have been notified that here at Aultman, we will receive a minimum of 975 doses for our critical workforce. And that is for all of our Aultman employees. And again, that's across our organization. A day or two later, after we receive our allotment, then other hospitals and health systems, along with nursing homes, will then receive their vaccine allotment. So when we talk about the critical workforce designation, that is something that here at Aultman, we've been working very diligently on to try to figure out who is that critical workforce. And so we have a tiering methodology that we have deployed that has 8 risk factors. So for example, one of those risk factors would be the level of exposure or the proximity to the patient. Another risk factor would be the length of exposure to the patient. So what is the time spent with the patient? And also another one is just the complexity of care provided to the patient. So obviously it would be our emergency department staff, as well as our critical care, other floors that are dealing directly with our patients, as well as our physicians and other disciplines that, again, are caring for those patients. One item too that we are planning on is to stagger the vaccination. So we know who our critical workforce, we've identified them, but then we have to stagger because we're very concerned that once the vaccine is given, meaning again, it's a non-mandatory, but it's if our employees wish to get the vaccine, we want to avoid call-offs due to the side effects or possible adverse reactions. So we actually are going to have a staggered deployment go on with our staffs. In addition, we know we have to educate our staff, and that is another big component of the FDA, EUA, is that we will get more information about the vaccine. So again, what are the side effects? What are the adverse effects? Give us some data. So we can get that out to our employees so they all can make informed decision about whether or not they will wish to choose to take the vaccine. We do have our medical staff leaders, our infectious disease physicians, our critical care physicians, many physicians that are endorsing this vaccine, as it again has been deemed safe and effective. In fact, it's deemed 95% effective. So we are very optimistic about this vaccine. However, we are going to be monitoring our employees through a database that will be sent to this at the state level. So we'll be able to monitor all of the outcomes from the administration of the vaccine. A reminder: the Pfizer vaccine is a 2-dose regime. So once we get the first dose, 21 days later, the employee will then have to get a second dose for full immunity. Another vaccine that's coming to market is the Moderna vaccine, and that is, I think, issued or is going through the FDA process as I speak. And that is actually also a 2-dose regime, but the first dose is given, the second one is then 28 days thereafter. So again, a lot of excitement about the vaccine, but we are really encouraging that besides to wash up, mask up, and back up, and boost up with your flu shot, now we want to arm up. And so we will be out there promoting this and getting as much information out to our employees. So with that, I'm going to now turn it over back to Barb, who is going to then now talk about contingency plans. Barb?
Thanks, Ann. In regards to contingency plans, each of our incident command teams continue to review data on a day-to-day basis. We can continue to stretch our abilities as well and have plans to expand as we need to. We kind of sort of laugh at times. You got to find the humor, but we kind of, our planning and contingency phases, they all continue to change. So here at Mercy, we have a saying, it's fluid and flexible. I have been amazed at how the staff and leaders have been able to adjust and adapt. We work diligently with our section chiefs along with the local emergency management. So we've definitely learned through that process. As we move through the next 6 to 10 weeks, we're going to be challenged. We will be challenged. As a community, we must heed the advice of Governor DeWine, the Ohio Department of Health, our local health departments. We do have additional contingency plans in place at the hospitals as we continue to plan for even more surge coming up. But I'm here to tell you, our staff, everyone suffers from COVID fatigue. Our staff is tired, they're stressed out. So I can't even ask or beg, we need to refrain from gathering this holiday season, as tough as it's going to be. Again, we need to mask up, we need to back up, we need to wash up, and now we need to arm up with the vaccine coming. I personally continue to get challenged about the reality of COVID-19, and to me, that's more exhausting than anything that we've talked about this morning. So I'd like to share with you a story about one of our patients who did pass away. It was published in the Akron Beacon Journal, so no privacy violations are being made with this. I'm going to read from the article. The headline was Akron-based Navy sailor, Ashland native, dies of COVID-19 at the age of 33. A family grieving after Nathan Bishop, a U.S. Navy Reserve sailor and Ashland native, died last week after a battle with COVID-19. The hardest part, his father says, is that we weren't able to say goodbye in person. I didn't think when we walked in the hospital that a week later he would pass away, said Bishop's father. He was a builder, second class Nathan Bishop, 33, died on December 1st at Mercy Medical Center. According to his family and Navy Reserve Force spokesman, his death was caused by complications of COVID-19. Donald Bishop, 60-year-old, his father, said that his son's death, especially at such a young age, isn't just surprising, it's heartbreaking. I laid on my floor in my living room and cried for 4 days over this, he said. What was more heartbreaking is that I couldn't go see him. It also shares that he was described as an outdoorsman and a sportsman who spent his free time four-wheeling and coaching youth sports. He coached baseball, basketball, and football near where he lived in East Sparta. He had a lot of friends and was easy to get along with, his father said. He was a great guy. He had a great smile. Everybody loved Nathan. I don't think he had an enemy. His father said the most important thing to Nathan was his 3 children. His family said that they're thankful for the staff at Mercy Medical Center who worked hard to take care of him and keep his family informed. They also urged everyone to take COVID-19 seriously. Even Nathan, in his 30s and physically fit, ultimately died from the virus. If you don't think COVID is real, I don't know what planet you're from, said Donald Bishop. Denny, I'll take it back to you.
Well, thank you for that. And that last message was extremely sobering. Thank you for our panelists. I mean, this is a lot of information, a lot of great information. And as I said earlier, what's so important is it's our local information. It's what we're seeing in our own backyards. I want to thank our panelists. I want to thank Dr. Boutros. I want to thank Ann Gunther, Dr. Kaeberlein, and also Barb Yingling. Thank you so much for being with us today, but thank you for what you're doing today. Thank you for what you're going to do after this webinar and in the ensuing days and weeks and months. Extremely appreciated. I also want to say thank you to Ed Roth and Tom Strauss, the CEOs of our 2 major medical institutions. We are blessed. We are blessed in this community to have Mercy Medical and Aultman Health Foundation and all the people associated, the doctors, the nurses, the administrative people, all the workers. Thank you so much for what you're doing on the front line of this, literally a battlefield. You know, my takeaway was just a couple of things I want to mention is we're running out of space in these institutions. And also the staff of these institutions are becoming fatigued physically and mentally. That's bad connection. We all everybody on this webinar needs to do our part. We need to do our part to help the economy, but we also need to do our part to keep our community safe. As it relates to our economy, you know, there are things that we can do and still be safe. We can, order, food online. We can order takeout. We have delivery. We can buy gift cards at locally owned businesses, small businesses in our community that need the support so much. And, shop online, shop locally. And if you are going to go to a business and that's your choice, be safe, be smart about that. I believe we have the 4 health commissioners on the webinar today, and I want to thank them for what they're doing in their communities. But it was also mentioned, we need to listen to the governor's information and mandates. We need to listen to our local health commissioners. We need to listen to the people that were on this webinar today, because it's real. The holidays are coming up. We need to make sure that we come off in 2021 as safe as we possibly can be. So to the businesses that are with us today, please take note of this, share this with your employees, share it with your families and others, and ask your employees to share it. And let's all be advocates for not just the business community, but for the health of our community. And the last thing is, I know we can all do this. We can all wash up, mask up, boost up, back up, and at the time available, we can arm up. So thank you to everyone who participated today. Have a safe day.